Welcome to the UC Quits webinar, the California Smokers Helpline, presented by Christopher Anderson. My name is Catherine Saucedo. I'm the Deputy Director at the Smoking Cessation Leadership Center at the University of California, San Francisco, and I will be your moderator for today's webinar. This webinar is one in a series of 5 webinars designed to educate providers on tobacco cessation and health systems change. The UC Quits project aims to further reduce tobacco use and exposure, the leading cause of preventable death, by developing a UC tobacco cessation network and UC e-referral system with the California Smokers Helpline. Headed by Dr. Eliza Tong from UC Davis, this ambitious project involves all 5 of the University of California health science campuses to ensure that every smoker receives support at every encounter. This system-wide collaboration is a historic change in how healthcare providers can ensure that smokers can get help to quit smoking by using the electronic healthcare record. Learn more about UC Quits at www.ucquits.com and the California Smokers Helpline at www.nobutts.org. And now I'd like to introduce today's speaker. Chris Anderson is Program Director for the California Smokers Helpline, operated by UC San Diego. He has been with the Helpline since 1992, when it became the first statewide publicly supported quit line in the U.S. Since then, the Helpline has become an essential component of the tobacco control infrastructure in California, assisting over 40,000 clients per year. Chris directs the provision of helpline counseling and other services and oversees outreach to public health and healthcare organizations. And now, Chris Anderson.
Thank you, Catherine, and thank you everybody who is taking this training. I'm very grateful for the opportunity to present to you. The California Smokers Helpline is a free telephone counseling service to help people quit smoking. It was established in 1992, and since then over 600,000 people across California have received service. That includes smokers and other tobacco users and their friends and family from all 58 counties in the state, which is an important point because in many of the more rural counties there really aren't other evidence-based tobacco cessation services available. Those who call the helpline are ethnically diverse. In a recent period over the last year, about 44% of callers were non-white. The same applies linguistically. About 11% spoke a language other than English, and the services are available in multiple languages, which I'll say more about in a minute. About 55% of callers to the helpline are female, which is consistent with other services, quitline services across the country. Even though women are somewhat less likely to smoke than men, it appears that they're more likely to reach out for help. That's certainly true for quitlines in the helpline. About 47% of helpline callers have Medi-Cal coverage, and another 24% have no insurance at all. So that gives you an indication of the low socioeconomic status of the typical helpline caller. And digging a little bit deeper in terms of who calls the helplines, we can also look at chronic conditions among helpline callers. The data I'm showing you right now come from a recent study with over 700 participants in which we gathered a little bit more information about callers than we typically do. And in that study we found that over half, or 52%, had some form of mental illness or substance use disorder. Nearly a third had a chronic respiratory condition such as asthma or COPD. About 37% had cardiovascular disease, and almost 14% had diabetes. And then another 39% had some physical disability such as blindness or deafness. And of course these percentages far exceed 100% because people could have more than one condition. But 79%, or almost 4 out of 5 of helpline callers, had at least one of these conditions. And it was very interesting to note that of those with at least one condition, the average number of conditions was 3.6. So hopefully these data give you an idea of some of the serious challenges that a lot of helpline callers experience in addition to needing to quit tobacco. So what are the services that the helpline provides? We provide self-help materials, written materials that they can read at their leisure. We also provide referral to local cessation programs. Most counties, although not all, do have some form of face-to-face or group counseling. And we maintain lists of those programs and provide them to provide a county list for everybody who calls the helpline. We're also able to provide nicotine replacement therapy for some callers. We're not currently funded to provide it to all, but currently all Medi-Cal members who call the helpline can get free nicotine replacement therapy, as well as callers who have a child 0 to 5 in the household. And those eligibility criteria are just due to the funding sources that are paying for that service. We also provide a full menu of after-hours recorded messages, so that if people call in the middle of the night, they can get tips on how to quit or how to get through withdrawal symptoms without smoking. There's also a text messaging service, which is available on the helpline website, which is www.nobuts.org. But our signature service, the thing that most people know about the helpline for, is telephone counseling. This is also the most resource-intensive service that we provide. And the telephone counseling consists of one call before they quit to help them plan a successful quit attempt, and then up to 5 relapse prevention calls to help them stay on track, to help them have a better chance of quitting successfully. And these relapse prevention calls are scheduled in kind of an interesting manner, and that's what this next slide gets at. What you're looking at right now is a typical relapse curve. This just describes the normal course of relapse in a population. In our case, we're looking at tobacco cessation, but the same basic idea would apply to any behavior that's difficult to change, like smoking. So what you see on the y-axis is the percentage of smokers who have made a quit attempt who are still abstinent at any point in time, and then on the x-axis you see time, days from quitting. So ranging in this case from 0 days to about a month and a half. And what you see is that there's a very quick fall off among those who have made a quit attempt. People are, if you will, they're dropping like flies in terms of their quitting. And within a week or 7 days, we've already lost about 60% of the people who have made a quit attempt. In other words, over 60% have relapsed to smoking. And then that relapse curve starts to level out. It's still going down, but the curve is less steep, and so they're relapsing at a slower rate at 14 days and then even slower at 30 days. So this, as I said, this is the normal course of relapse for the change of any addictive behavior. And so what and I should also say that in most face-to-face or group programs, if you're familiar with those, the typical schedule for sessions or classes is usually weekly, and that's it's not clear that schedule is designed for efficacy. It's more for the convenience of the participants or the presenters. We're geared to just meet once a week, I guess. But with telephone counseling, you have the unique opportunity to schedule it when it's most useful. It doesn't have to be weekly. And so that's how helpline counseling is scheduled. The vertical lines show the scheduling of the relapse prevention sessions that are provided to program participants. And as you can see, they're front-loaded. So early in the quit attempt, when the likelihood of relapse is highest, the calls are most frequent. So we typically call them on their quit date, day 1, or within 24 hours, and then on the 3rd day, and on the 7th day, at 2 weeks, and at a month. So as they're becoming more confident in their quit attempt and less likely to relapse, then the sessions grow farther apart. And so, and now I'm going to show you a relapse curve of a different sort. This is the same basic idea, but now we're looking at the outcomes from a randomized controlled trial that was done to establish the efficacy of Helpline counseling. And because it was a randomized controlled trial, there were different groups of people who were randomly assigned to receive a different service. And the bottom curve that you're looking at is a group that was randomly assigned to receive just self-help materials. The second group above that was assigned to receive the self-help materials plus one session of counseling just to help them prepare to quit. And then the third group on top got all of that, the self-help materials, the single session to help them prepare to quit, plus the relapse prevention sessions that I was just describing. And so what you can see is the outcomes over time. On the y-axis, we still have the percent abstinent at any given point in time. And as you can see, it follows the same general pattern that there's a quick drop-off and then it starts to level out. But the interesting thing to note here is that there's a clear difference based on what type of service they received, or more precisely, how much service they received. So the group that was the control in this case, the self-help group, had that very steep drop-off in the first few weeks of quitting, and it leveled off at a much lower level than the other groups. Going up from that, single counseling had a significantly higher rate of abstinence from smoking at 1 year, and multiple counseling had an even higher rate at 1 year. And so basically, the single session was effective. That's a significant difference there between those two curves, and the multiple counseling imparted an additional benefit on top of that. So overall, and this is the basis of the claim that the Helpline makes, which is that multiple sessions of telephone counseling roughly double participants' chance of quitting long term. And these results are from an early trial of Helpline counseling, but it has been replicated in several studies since then, and consistently we find the same doubling effect. So this is what provides the confidence that the Helpline counseling is efficacious, that it really works. So you may be interested in knowing a little bit more about what the content of the counseling. What is it that the counselors cover with participants as they're going through the program? And there's a lot to it, but it can be boiled down to 5 basic elements. Basically, the Helpline counselor is trying to help the client to do these things. One is to identify a strong reason to quit. And the counselor is not imposing a reason on the client. It's not really even necessary to do that, because most people who smoke really do want to quit. They've got their reasons. Maybe they haven't articulated them before. The counselor is trying to pull that information out of the client, get them to express it in a way that's meaningful to themselves. So we work on their motivation. We also work on their confidence, and by that I mean that a lot of people who have tried to quit feel like failures. I guess they believe that they should have been able to quit the first time or the second time. Having made multiple attempts makes them feel like maybe they can't do it. The counselor tries to reframe that, reframe their previous quit attempts as valuable experience and evidence that they really can do it. They've quit before for a day or a week or a month or whatever the case may be, and reframing those as past successes helps to build their confidence. The counselor also tries to work with a client to develop a solid plan. So this consists basically of trying to think about what are the situations when they're going to want to smoke, the trigger situations or temptations, and what are they going to do when those situations come up. It could be that they're afraid of alcohol. Alcohol is going to make them want to smoke, and maybe it would be possible for them to avoid alcohol for the first week or two. Maybe it's a friend who always wants to smoke with them. Maybe they can just talk to that friend on the phone for a week or two. Maybe it's highly emotional situations, and there's a way that they can restructure their commitments temporarily so that they're not going to be placed in those highly emotional situations and won't want to smoke. There are various ways of dealing with the triggers, and by taking them through an exercise of coming up with coping strategies for those triggers, it helps to build their skills for quitting. And the fourth element that we work on is their self-image. A lot of times you hear people who have quit smoking say that they're still a smoker and they could go back to smoking at any time. That may be true, and maybe that's how they need to look at it. But if they're open to it, we favor a different idea, which is that you try to become the sort of person for whom smoking is not even an option. And then, so you really adopt a new self-image, that you try to start to see yourself as a non-smoker, not just as an ex-smoker. And with the idea that that self-image as a non-smoker gives you some protection from the continual likelihood of going back to smoking. And the final element that we work on with clients is perseverance. Just this idea that you've got to keep trying, that it's very natural, it's very normal to have to make multiple quit attempts. And in fact, the quit attempts that the counselor is working on with them right now may not even be the last one. But the important thing is to keep going, keep trying. And it's very common in the course of the relapse prevention sessions to find that the client has either made a quit attempt and gone back to smoking, or they've made they just never really got off the dime. They intended to quit and they were going to, but the morning came and they didn't quite do it. It's not a big deal. That happens. It's normal. We just try to encourage them to get back in the saddle and try again. And that if they do that, if they don't give up trying, then they will be successful. So we've talked about some of the evidence for Helpline efficacy and what the content of the counseling includes. I'm going to shift gears now a little bit and talk about how the Helpline is promoted, because it's important for healthcare providers and other professionals to sort of know what their patients are seeing about the Helpline before they come in for treatment. And so what you're seeing right now is sort of a classic ad. There have been many, many different ads promoting the Helpline over the years, but this is a kind of a classic created by the California Department of Public Health. It was a billboard. As you can see, it co-opts the Marlboro imagery and typeface and whatnot to sort of subvert the glamorization of tobacco and turn it on its head. So we're de-glamorizing tobacco use with this ad. And in that context of the overall state effort to denormalize tobacco use, look how easy it is to just append a message about how quitting is easier with help. Call the helpline, 1-800-NO-BUTS. It would be very difficult to incorporate that kind of cessation resource into programs statewide. But this is one billboard that was created for the whole state, went up all over the state, promoting that one phone number. So there's a certain benefit to the centralization of tobacco cessation services through the helpline. But that's an example of a general market ad promoting the helpline. And in addition, there have been radio and TV ads and many other ads in many other media. So what you're looking at right now are some of the more ethnically targeted advertising. So just as the tobacco industry spends enormous resources to try to figure out how to promote their products to all segments of the population, the tobacco control program also has to be smart about how to promote to different groups. So we see here an ad targeting African Americans, another targeting the Latino audience, and a third targeting Asian audiences. And that Asian ad was also produced, this one is in Chinese, but it was also produced in Korean and Vietnamese languages that are served by, all of these are languages served by the helpline. And I should note also, just to go back for a second, that there's a different telephone number for each language, so that when somebody calls the helpline for the line for their language, their entire experience is in language. They never have to fumble around with an English speaker. They get the service in their language immediately. So I showed you a couple of examples of general market advertising and also more targeted advertising geared toward consumers. In more recent years, the Helpline has also done advertising directly to healthcare providers, and there have been many different campaigns along these lines. I'm showing you now one that was geared toward OBGYNs, just making the point that the healthcare provider has a great opportunity to share their advice with the tobacco user that they would be much better off if they quit smoking. And so it educates the healthcare provider about what a great opportunity they have to influence the patient's health through their behavior, such as stopping smoking. And so this particular one was paid for by First 5 California, which is one of the other funders of the California Smokers Helpline. And as I mentioned, there have been many other ads targeting different types of healthcare providers, but most of them employ this basic three-part call to action, which is to ask all your patients if they smoke, advise them to quit, and refer them to 1-800-NO-BUTS for free telephone counseling. So this is an example of an ad that was developed for nurses, and increasingly also the Helpline provides other training and technical assistance opportunities for healthcare providers and other professionals to learn more about treating tobacco use. So this one had free CE courses that were available through the Helpline website, and those resources and more are still available at www.nobuts.org. This is an example of a material that was developed several years ago, again with the theme of Ask, Advise, Refer. It's a poster that was distributed to healthcare providers and systems, again giving more information about Ask, Advise, Refer in more detail. So I wanted to also share some information with you about how this approach of working with healthcare providers to partner with them and to ask them to intervene with their tobacco-using patients and refer them to the Helpline, how that has paid off over time. So referrals have steadily increased over the years to the point where they account for the largest share of calls to the Helpline. And so you're seeing some stats here from the last year. About 42% of Helpline callers said that they were referred by a healthcare provider. About 32% were referred by the media campaign. About 16% were referred by a friend or family, and it's that could have been because of a healthcare provider talking to the friend and family member, or it could have been media. It's hard to say. And then another 11% were referred by some other source. So this really shows that healthcare providers have already been playing a really critical role in communicating information about evidence-based services to their patients. And how do we help them do that? There's lots of free materials that are available. Again, the website is on the bottom of your screen there. And so there are, in the lower left corner, there are cards for English and Spanish speakers. On the right side, there are brochures that are available in language. And all of these are available for free through that website. So what we've been talking about so far is just advising the patient to quit and referring them to the Helpline and handing them one of these materials, a gold card or a brochure. Another way to refer patients to the Helpline is what we would call the broad category direct referral. And it could be in several different forms. It could be in the form of a fax. It could be a web-based referral. And recently we've been doing some pilot work with e-referral or electronic referral. What I'm talking about here is instead of just expecting telling the patient to call the Helpline and expecting them to call, in these cases we're asking the patient for their consent to be referred to the helpline, and then the helpline will call the patient. So that information can be transmitted to the helpline either by fax or over the web or through electronic referral. And that last one, e-referral, means that the referral is coming directly from the electronic health records for the patient. And the benefit of these direct referral mechanisms is that it provides the provider with greater assurance that the patient will actually receive the treatment. Because as you can imagine, patients do want to quit, but they have a fair amount of ambivalence. You know, maybe they want to quit sometime, but not right now. And so the helpline does not share the patient's ambivalence. Of course, the helpline wants the patient to quit and is ready to help. So by putting the onus on the helpline to contact the patient, it increases the likelihood that the patient actually will. Now, these direct referral mechanisms really are most suitable for the patients who do want to quit, and of course that they provide consent to have the information shared with the helpline. And when the helpline receives the referral, then a counselor will proactively reach out to the patient, and they'll make up to 5 attempts to try to reach them. So what you're looking at right now are just screenshots from the web referral. And I just wanted to give you a sense, because this tool is available right now to all clinicians across California. Wanted to give you a sense of how it works. It's just very easy, and we really tried to make the information that needs to be entered as streamlined as possible. We just ask that the provider identify what organization they come from, and there are drop-down menus there. And if the organization is not yet on the drop-down menu, then there's a registration page which allows the provider to sign up. And once they've signed up once, then they can refer any number of patients after that. Next, we ask for information about the patient, including their first and last name, their date of birth. This is for identification purposes. We ask for their phone number and an alternate phone number if possible, which increases the likelihood that we'll get a hold of them. And we ask that the patient's preferred language be specified. And these are the 6 languages that we're currently able to serve: English, Spanish, Cantonese, and Mandarin, Korean, and Vietnamese. If there are any comments that the provider would like to add, there's a space to do that. And the last step is just to ask the patient for their consent to have the information shared with the helpline and to have the helpline contact them. So we ask the provider to read this consent aloud to the patient, and then just check the box when the patient provides the consent. Type in that code just to make sure that you're a person, not a machine. Click Save, and then the referral goes immediately to the helpline, and the helpline starts making attempts. So just to wrap this up, I just wanted to, what I'm hoping is that you will come away from this talk with a few key points. And first of all, that the helpline, the California Smokers Helpline, is a free service that is available in multiple languages, that's very easily accessible to anybody who has a phone or can access or can even use a friend's phone, and that it's effective. There's evidence that the telephone counseling really does help smokers quit. Also that I hope you come away with a sense that the general anti-smoking media campaign that's out there in the state is creating some basic level of awareness about the helpline among patients who use tobacco, and it's also increasing their desire to quit. And maybe all they need at this point is just some trusted healthcare provider or other professional to tip them over the edge, to spur them to take action. And so what that action could consist of is, of course, advising them to quit, but then referring them to a place that specializes in helping them do just that. And I hope you came away with the idea of how quick and easy it is to refer patients. Number one, free patient materials are available on the helpline website at nobuts.org. And then if you're interested in directly referring patients to the helpline, you can sign up at nobutts.org/referral.
Thank you, Chris, for your presentation on the California Smokers Helpline. Great resource for providers and smokers alike. We are pleased to offer free CME CEUs for those who complete this online activity. The webinar link and instructions to claim credit will be posted on the UC Quits and CME California website. For questions on the UC Quits project, please contact Dr. Eliza Tong. Thank you for your time and interest, and remember, every smoker, every time. Thank you.